So good evening and welcome, you guys, to the Project Radical webinar series. My name is Shay Bearfield, and my co-moderator is Upal, I'm going to get this wrong, right, Basaroy. Did I do that right?
You sure did, friend.
Hey. And so we are told, I want to introduce the panel. Do we have Dr. Farhood here?
Hi there.
Hey, Dr. Farhood. And we have Dr. Morhoff.
Hello.
And we have Dr. Maisha.
Hello.
Hello. Upal, do you have anything you would like to say at this point?
Good evening, everyone. For those of you who don't know me, Upal Basra, and I work for Longevity Foundation, where I manage a research program. And I also wanted to invite our very special guest, Nikki, to today's panel discussion. I see Nikki's also on.
Okay, I did not know that. So thank you for seeing that. I would love it if the panel would introduce themselves so that other people who are here would know who you are. Tell us a little bit about yourself. Let's start with Dr. Farhood.
Hi there. My name is Farhood Farja. I'm a thoracic surgeon and I work at the University of Washington in Seattle.
Wonderful.
Thank you for having me.
Thank you for being here. Dr. Morhoff.
Hi everyone. My name is Morhoff Alashkar. I am also work with Farhood at the University of Washington. I'm a family physician by training. I'm also a stage 4 lung cancer survivor.
Wow. And Dr. Maisha.
Good evening, everyone. I am Maisha Standifer. Professionally, I am the Health Policy Director at Morehouse School of Medicine, Satcher Health Leadership Institute. And personally, I was a caregiver to my husband of almost 11 years, Emmanuel Standifer, who created what's behind me, a podcast focusing on cancer survivorship. Folk, I got something to say. So I'm so glad to be here this evening.
Yay. Upal and I met yesterday and we were discussing how we wanted this to feel. And we thought, you know what, I think it should feel more organic in terms of conversation and things that can come out of it and we can all learn. One of the first places that we want to start, we want to ask questions around treatment. And is that all right? Mm-hmm. So one of the questions I'd like to know is, what did treatment look like for you in terms of, now I see that did your husband, Dr. Maisha, have lung cancer?
Yeah.
Oh, we forgot to introduce Nikki.
There's
Pause.
Nikki, yes.
Sorry, yes, because she wasn't on my notes. Isn't that terrible that I didn't know how to deviate from this? Nikki, can I see, let me go here to see you. There you are. Nikki, please introduce yourself. And I wished I would have known more information. Please tell us about yourself.
She can unmute herself. She can unmute herself.
Yeah.
Maisha. So I am an invited guest by Dr. Maisha and also a friend of hers of many years, and I knew her husband, Emmanuel. Nice. I've been in the cancer space for over 14 years with a top-ranked cancer center here in the Tampa, Florida area. I'm the founder of a new LLC called Ladder Up, and my experience in 14 years in this space, I started out in the diversity department. So I have a lot of knowledge in diversity, community engagement, and outreach. I also was a patient navigator, primarily to like low income programs and our communities. And I created a program, a kids program, because I felt like that prevention starts early. And so I this topic about lung cancer, particularly just the lung in general and lung health and the dangers of smoking. So I've had over, along with my mentees, over 25,000 kids in our Bay Area sign tobacco-free pledge cards. So this is something I'm very passionate about, advocacy for prevention as well.
Thank you, Nikki. The first question I'd love to ask the panel is, can we ask questions around the element of treatment? What did treatment look like for you? Starting with you, Dr. Maisha.
Yes. And so I guess just briefly I'm sure I'll continue on throughout the panel, but my husband was diagnosed with stage 4 lung cancer in March of 2020. and he succumbed to complications due to lung cancer in April of 2021, earlier this year. But treatment along the whole process, initially, Shay, is that he was first asked to do chemotherapy at the hospital because that's where he was first diagnosed. And immediately the hematologist there wanted to start him off on a chemotherapy regimen. At that time, I was very familiar with a Tampa-based cancer center. And I reached out to some individuals who told me about genetic testing. And within that 2-week time span of my husband being diagnosed, we were on a genetic testing regimen, and he was found that he was ALK positive, and that's where he started the oral therapy treatment for his lung cancer and maintenance. So that's the start.
What is ALK positive?
And I'm sure everyone else could tell you a little bit more in terms of the oncologists that are here, but it is a gene mutation that was part of for his lung cancer specific. So it's a special a mutation that Upal and Morehoff could talk a little bit more about that he was that he acquired. So he was ALK positive. There are other genetic mutations for lung cancer, but he was ALK positive. And so there's specific treatment for genetic, mutations of all cancers, right? But specifically for lung cancer, he was put on a treatment regimen and various medication there. And there's first line, second line, and third line treatment mechanisms. And that's how his treatment first started off.
Sure.
And I'm sure probably Morehoff or Upal can go a little bit more into detail about the specific ALK positive mutation.
Just out of curiosity, and then I want to move on to the next one. Tell me, did you find the treatment, was it easy to get? Was it accessible, said treatment? Someone tells you about this genetic mutation. We want to know, how did you find the treatment? Were the people kind to you? Did you feel protected, safe, advocated for?
Well, I'm glad you said that.
I'll just quickly follow up on Shay's question, Dr.
Yes.
Maisha. You mentioned something where you said that your husband would have gotten chemotherapy if you had not been an advocate and you had not done your research. Can you unpack that for us a little bit more?
Yeah. And so I'm glad you said that, Upal, because you asked that because, of course, my background being a cancer disparities researcher and working formerly at a cancer center, I knew that there was a number of research opportunities, options that were available for cancer now, right? Talk about personalized medicine. And I had so happened at least 3 years prior to this diagnosis was at a conference at this cancer center and heard a lung cancer researcher talk about a novel, innovative therapy for lung cancer. And that obviously stuck in my mind because as soon as my husband was diagnosed with stage 4, I immediately thought of this presentation that was held 3 or 4 years prior to this, right? And so then I thought, wow, let me contact individuals that I know at this particular research institution. When I did, I was immediately connected with the researcher who gave that presentation years before, who was a prominent researcher in the area of genetic mutation and lung cancer treatment. We met with her and she fast-tracked us on to, again, I think there are separate things because we had insurance that covered this, and we were able, and of course the knowledge and the advocacy, Upal. And I persistent because again, my husband was still in a phase of shock. We both were, but being a researcher, I think that pushed me to say, no, I know there's something better. So I was in I flipped from wife, from mom, and all of those things that came upon me immediately to being that patient advocate for my significant other. And so that pushed me to say, no, we got to find something. I have to, help him live. That was initially my thought. And I think, to me, it worked at that time. And I can talk a little bit later about maybe I should have also let him live as well as how he wanted to be. And I think that's something I had to balance because I was pushing toward, hey, what's the best treatment? What do we have to do? As opposed to accepting what it is and going through that process. And I think that's something, you know, I'm talking with other people who are grieving and mourning from individuals who are from death of cancers. And I think, you know, if I had to look back, but I think the treatment option was well intended for what I wanted to do because of the advocacy and the knowledge and the expertise that I knew other people had. And that's what I tapped into.
Thank you. That's a great question, Upal.
Yes,
Nikki,
thank you.
Nikki, I would love for you to answer regarding treatment. Like, how did treatment look in the world? I know you're an advocate, but clearly there are people you know and love who are getting treatment. How does treatment look to you guys? How did that look?
Well, you know, I think that treatment has a different face,
Mm-hmm.
And look for different people. And I would like to say what I didn't say is for the past 6 years, I have had the privilege of working in the public relations department. So I consider myself a PR pro. And with that assignment, I also blogged. I blogged for the Cancer Center, and I had the very distinct honor of writing Dr. Maisha's husband, Emmanuel's story. And I will tell you, you know, that's something when you're telling the patient's story is such an honor to be able to tell someone's story, because while I wasn't the one going through his pain, his hardship, the decision-making, you know, I had to write it and tell his story. And I want to say that, you know, just to piggy up what Dr. Maisha said is that, you know, I also interviewed her as well. And she, you know, she had to wear several hats. Right. When you think of hats, you know, she put on her research hat, you know, that advocacy hat for her husband. But that where's the balance of where then you also have to be that wife. She's a mother. She had to be that mother, you know, and she was that friend. And I think that caregivers, you know, they don't get the break that they necessarily deserve. And so, you know, I will also say that because of Dr. Maisha's knowledge in the field, if we're to really truly talk about health disparities,
please do.
The grassroots community, the grassroots family, which are typically our Black and our brown families and community, is that, you know, they don't necessarily have that knowledge. They're more concerned about, like, especially with inflation. I mean, look at the gas prices. They're trying to figure out, how are we going to pay our electric bill? You know, how are we going to do the laundry? You know, the kids and COVID, and yet you've been diagnosed with a terrible cancer disease, and then we're talking clinical trials. I mean, we could have a program on the lack of knowledge and what clinical trials look like in the Black and brown communities. Someone like Maisha, she knows what to fight for, but you know, she's in a very, very special category.
That's my point.
Of people, they don't. Matter of fact, they're
not Dr. Maisha.
They don't even know how to access getting help. Where do I go? What treatment? The stereotypes. I don't want to take over the conversation, and I hope that we can have more conversations. But I can tell you that I've personally witnessed a lady who had stage 4 colorectal cancer, and it did spread to her lungs. And she was told at a low income health clinic that there was nothing we could do for you. There's no help. Me as patient navigator at that time brought her out to this top ranked cancer center that, first of all, she didn't even realize that she would even have access to.
Right.
You know, I you know, when it comes to healthcare, you should be able to go to the best, regardless of insurance. And so she was told that there was nothing that could be done for her. And thankfully, we got her out to the cancer center. And while she did pass away from the disease, she felt respected. And that's also areas, how to treat these people that are going, you know, less than, or do we treat them equal? as if anyone else, if they were economically secured.
There are two things that I want to pinpoint and ask and leap off of. One is, what happened that made her feel respected? What would you say her feeling respected in her last days or even in this process was?
Great question. It was the patient care.
Mm-hmm.
It was that she was made. I remember her saying, she said, I won't die until God calls me to die. But this, I believe she was probably like a nurse practitioner to say, told her that there was nothing, took her hope away, took her breath away. And at least she was given the decency and the respect and the care and treatment and patient care. Patient care is critical because it's also in the mind. And just so many people are, it's kind of like the who's who. I hate to come down to that, but we're still battling, on whether, this person, because they're low income, do they deserve, or they're an immigrant, do they deserve medical care, good medical care? And I guess that's, the $1 million question that's, constant, that's in a battle that we're battling over. And you know what? Her name was Judy. I can say that. Miss Judy.
Hey, Judy. Miss Judy.
That's right. And she left this world, but she left knowing that she was cared for.
And what I also hear in your story is that she left this world with you trying to provide a solution for her. So even if the end of the try wasn't that she lived or that she was whole or healed, she saw people advocating on behalf of her and trying on behalf of her. And that's a wonderful thing. Yeah. Dr. Maisha said something that I just want to jump on before I go to Dr. Farhood. And that is, you said that you'd gone to a conference and you heard about this thing. I just want I would be remiss if I didn't say, oh my goodness. So her husband was able to even access or knock on the door of this treatment because his wife had access to conferences that talked about these cutting edge things. The average person in America does not. Exactly. It's like he had the perfect wife to get the ailment that he got. Yes. And unfortunately, I would say, I'm pulling the statistic out of my own brain, but I would say probably the gross majority, 90+% are not equally blessed to have a researcher wife in the vein of lung cancer.
And just to add to that, just really quickly, Shay, is that it was very interesting. And that's what, when I tell people my story, people are like, oh my gosh, unbeknownst to me, did I even fathom that this would be the case, right? But knowing the statistics, right? It should not be a shock. So that's why we're here, increasing, informing, and educating. Yes. And that's why I joined along with Morhav and Upal and all the other team members of Project Radical to really make this a point. And we're setting aside all of our Mondays and Thursdays of this month to really focus on educating the population, general public, clinicians, all that are there. But to highlight too, just to add, is that I also found it to be, if I can speak, my husband's perspective is that he was also someone, who would think that he have a researcher, wife, but he was also a little hesitant of the medical community. And as I've talked previously about who is saying in terms of the face, what it's looking like, what, race or nationality, who is providing this information, that was key to him. Yeah. And in the hospital, it wasn't a friendly environment. He was there in the midst of COVID, where there were people, he was there by himself in the hospital, isolated. And so I was only communicating him through the phone. So even understanding that. And so when we were taken to, as Nikki talked about, the space and the place of caring, which this cancer center did, and there was a face on the other side of this information that was the same hue as his.
Yeah.
That looked like maybe his sister or his mother. So, I think that was, he told me later, I think I trust her a little bit more because, she probably relates to me a little better. And this was a researcher who was African-American. And what she said is that, I'm going to do the best that I can do with the best of what I know. And that resonated with him. And I almost saw a burden lifted off of his shoulder in a way, as opposed to, because I had to understand my husband also had a family history of lung cancer. Grandmother passed. His father was diagnosed with lung cancer 3 months before that. His aunt had passed. So there was a family history as well. And there was a family history of chemotherapy, and individuals did not survive the chemotherapy. Yeah. So he saw this as a death sentence. Well. Yes. Mm-hmm. And so he said, he even told me, I'm not going to do chemo. I'm not going to do it. I'm not going to do it. So when the option of clinical trials and oral therapy was provided to him by a familiar face, or a face of the same hue that had the background possibly of him being from Florida, he said, I think I trust this person with the treatment. And that's what he did.
I love it. Thank you so much, Dr. Maisha. Dr. Farhood, I was talking to Upal about this, and I'd love to ask your thoughts on this. I just recently changed my primary care physician, and being on this board and it has been life transformative for me. I am now someone who is passionate. Like, I'm that person at the dinner party who wants to tell everybody, like, did you know that lung cancer is the #1 killing cancer in the country? Like, and say, like, really, the only thing we talk about is ceasing smoking, but really we need to have early detection. And so I'm going off about this with my new primary care physician. And he said to me, he goes, Shay, I hear you. Yes, you're right. It is a deadly cancer. It is the #1 killing cancer. Most people think it's breast cancer, but in fact, it is lung cancer. And I was like, so we need early detection. Why aren't we getting every year when I go to have my physical, why aren't you checking me for lung cancer? Why is this not the case? And he said, I understand what you're saying, but the problem with it is there is no real great test to see it. And the MRIs and all of these things that we put people through seem to create greater fear on the back end versus actually early detection. So my question to you is, what would you say to that?
I'm glad you asked that question. So in terms of early detection, in 2011, there was a really important study of 50,000 Americans that was published, and it showed that for a certain group of people, if they got screened with a CAT scan of the chest, that their chances of dying from lung cancer would be reduced by 20%. And I realize that's a number, and it depends on your view of numbers. Is that big or small? But just to put it in perspective,
it's a life.
It blows away all the other screening interventions for other cancer types.
Really?
Yes. So it's
like breast cancer. Do you know
breast
the number
cancer,
there?
Colorectal cancer, prostate cancer. Now, the Europeans also recently published a trial that showed a similar effect of screening. So this is a huge advance in the field because we have not had a screening tool. The issue is that it's only for a segment of the population. So until recently, it was for folks who had smoked. And the amount of tobacco exposure was high. And if they had quit smoking, they had to have quit within 15 years. Recently, some of the guidelines have changed, and the amount of tobacco exposure is not as much. But the bottom line is the screening tool isn't available for everybody. And I think reflecting on what your provider, your clinician had told you in response is that these screening tools, these CAT scans, are not benign. they have a little bit of radiation associated with it, which over time can add up and actually lead to cancer. There can be false positives. And if your provider doesn't know how to interpret that cautiously, the next thing you know, one test will lead to another. And the fear is, and we've learned a lot from actually breast cancer screening, is a lot of unnecessary procedures. So all that is to say that there has to be a balance between the benefits and the risks. And so we know in this specific population that's been studied that the benefits seem to outweigh the risks. But if we now apply that to everyone, we might actually be hurting people rather than helping them.
So I have another, thank you for that. And because that leads me to the next part of what my provider just told me. He said, so also, Shay, we don't have a definitive group. When you're doing testing, you need to have your test group. You need to have so who is that group in lung cancer? And I was like, oh, so what would you say to that?
For the screening, is that?
Yeah, for the screening,
Yeah.
like, because
Right.
he's saying, anytime you are going to say, we're going to do early detection and we're changing and shifting how this medicine is going to move forward, you have to have a control group. Who is that control group? Who is the group that you're seeking to create or alleviate lung cancer out of? It can't be everybody. So who is that group?
Yeah.
So that left me a little befuddled, and I'd like to hear your thoughts on that, Dr. Farhood.
Yeah, so the group that currently we know that the benefits outweigh the risks are folks that are age 50 to 80. They've what we call 30-pack years of smoking, which you can think about as smoking a pack per day for 30 years, and those who quit within the last 15, with the revision of the guidelines being 20-pack years.
Okay.
So that's the group that the screening benefits. I think we have to acknowledge, because there's a real issue with lung cancer and stigmatization that exists in this country. And that is 1 out of 5 people who get lung cancer have never smoked. And that's a lot of people when you think about how common lung cancer is in the population. So
20%.
Yeah, 20% of people have never smoked and get lung cancer. So unfortunately, right now, that's a segment of the lung cancer population, or people who eventually get lung cancer, that we don't have early detection tools for. And the concern is if we just launched all our diagnostic tests right now, we might actually cause more harm than good in those folks. So that's an area of investigation. That's an area that we need resources, we need funding to do research, because a lot of people can benefit from this scan, as long as we can narrow in on the people who are at highest risk for lung cancer.
Thank you. Upal, please.
Oh, I had a follow-up question for Dr. Farhood, which is related to access to lung cancer screening. And we know that, yes, we have lung cancer screening, and we know that Black community members don't have access to lung cancer screening in the same fashion as other community members. And what are your thoughts about that, Dr. Farhood, and how can we as a community make lung cancer screening more equitable?
Good question.
Yeah, it's a great question. And I think that there are, let me focus on a couple positive things, then focus on a couple opportunities. So the Affordable Care Act actually made it law that commercial insurers have to cover screening interventions that have a grade A or B by the USPSTF, which is the United States Preventive Services Task Force. So that is a structure that actually promotes lung cancer screening. The problem is, as we all know, there are many Americans without insurance, and that is disproportionate in people of color. So this important structure does not address that problem in our society. There are institutions that have tried, especially academic institutions or hospitals that are safety net, to have programs for the community, so that for those high-risk individuals who benefit from screening, even without insurance, they can access it. But to be frank, there's a lot of variability in how that's rolled out across the country. Other issues that have to do with access are not as, they're not necessarily tied to insurance, but if you think about most people, they work. And so access sometimes is getting to see a doctor, getting to a CAT scan when you're not working, and taking time off work is really hard. So one opportunity moving forward to eliminate disparities is to create greater access to clinicians, to CT scanners at night, on weekends, having a flexible approach so people can that have the insurance or have the programs that support them can actually access the care, whether it's the clinicians or the scans. Other things that people are doing around the country that are quite innovative is they're taking the scanners to people. So some institutions are literally buying trucks. And I think this has been done in breast cancer screening and other cancer sites. But basically, they're loading up a big truck, they're putting clinicians in there, and they're putting a CAT scan in there, and they're going to the people. And this is particularly helpful in rural communities where it's a long drive to the big hospital or the big cancer center. And that's another way that that folks are trying to combat the disparity that exists with lung cancer screening.
Thank you so much, Dr. Verhood. Upal, do you have another question for him?
I had a question actually for Dr. Morhav. And you are at today's discussion wearing some very unique hats, one of a patient and that of a primary care provider as well. And can you talk a little bit about how your experience with lung cancer treatment was? We heard from Dr. Maisha that in her case, a lot of stars had to align for her husband to have access to the right treatment. And we know that alignment is very tricky. In your case, how did the stars align, for lack of better words, for you to have access to the best treatment possible?
Thank you, Upal and Shay for leading the discussion, and also Maisha for sharing the story and letting us learn about Emmanuel's. Actually, I want to say Emmanuel was also my friend. We had planned to come to Seattle, and I had planned to visit. COVID came in the way. Unfortunately, I could not meet him in person, but we met virtually many times. He called me brother because we had cancer cells in our blood. So, we were kind of cancer brothers. My experience, I'm a physician and I am a primary care doctor, so it was easy for me to get the x-ray and get the CAT scan. The first conversation, and I would share generally about treatment. Generally, historically, with lung cancer, if you have early stages, you would receive surgery that can be curative. If you have advanced stages, that's where historically chemotherapy, radiation could play a role, or played a role. With the development of molecular testing now, there is immunotherapy and there are targeted therapy. If you harbor those the mutations or the markers that can make you eligible for one of them. I am also an ALK positive person, and I've survived 2016. November actually marks 5 years since my diagnosis. When I was diagnosed and I presented to the oncologist, the conversation was actually not very different from what Maisha and what Emmanuel had of a conversation. And I am a healthcare provider. I was told 2016, this is not many years ago, I was told you have stage 4 lung cancer, and you know what stage 4 lung cancer. So there is those kind of fill in the blank, kind of you know what it means. And I did. And he said, it's palliative treatment, and that chemo, radiation might be needed. I had pleural effusion, so it's not a lot needed. I did not have did not actually get a brain MRI until I said, I am going to get a second opinion. And that's when he said, oh, let me get that brain MRI. Brain MRI was necessary to see whether the medicine that I would get, crizotinib at that time, would be the best choice or something else, even after I was diagnosed with ALK. So there were some missing steps in there. So I, the healthcare provider who went to see a colleague of mine, there were this issue. I had asked on a Friday, I was frantically talking to the pathologist at the lab, saying, "Hey, I just talked to a cancer survivor, and he said you have stage 4 lung cancer. You have no time. Get your molecular testing." And when I was talking to the pathologist, "Can I get molecular testing?" I paged them, of course, and I got access to them, talking on the phone. He's like, "Which molecular testing? Which tests do you want?" So they were not even a standard order at that time. That's 2016. And I wonder if this situation has changed and whether it changed in some institutes, but not in other institutes. I had lung cancer, again, stage 4 adenocarcinoma. So it's the one that's not associated with smoking. When I was presented to the oncologist, he said palliative treatment, which is understandably so. And he introduced the molecular testing as there are some people nowadays who are doing molecular testing. And I said, yes, I want that. So even I, primary care provider, physician, colleague, said, I want that option. It wasn't offered to me as in, we're going to do this. It wasn't done, of course, which I think it should be. You know, you got adenocarcinoma, lung cancer, stage 4 before. That should be an automatic test. Why is it the patient that has to say, yes, I want that? And of course, I can imagine with many other people, as we discussed before, if I have concern about the bill that's going to come to me, or if I don't know what those mean, what does molecular testing mean for somebody who have low health literacy? Even I myself, as a primary care provider, knew nothing about molecular testing, about what's happening in lung cancer, because this is way above my pay grade. Farhood is a lung cancer researcher and he's a surgeon, so that's his focus. Now I am a cancer survivor and I have learned about cancer because of that. But at that time I did not know much, and it was offered to me as there is this option. Do you want it? Well, many people I imagine who were offered that same thing would have said, no, I don't want it. What is it? What is it going to be? It's like, oh, there's a chance that you're going to have that. So I am curious, actually, how are those conversations happening in the community? And I'm curious, are they happening in the same way, whether you are the rich white person, or you are the poor black person or immigrant, or we were the person who show up in the emergency room and get diagnosed with those with advanced cancer, and then we're scrambling to find the safety plan for you, but really there's no follow-up, there's no PCP, there's no oncologist, and we're going to have to get you into the system now so you can catch up with all this learning to become your self-advocate. This is not going to happen. You're going to die before you learn how to survive the health system and how to navigate the health system. I think that's a huge part. So that's my experience, and it's frustrating, it's angering, and I see its outcomes. And the outcomes doesn't. And this problem does not end just early on with getting molecular testing or not. Although this is a life-saving, or I would say death sentence. If you're advanced lung cancer and you can't have that and you're not getting it, then you're really let to die. And that's failure. That's not just failure, that's crime. I would call it a crime. And there are a lot of people in our community that are left to die because they're not offered this treatment. But I would say further, more than that, those molecular testing would work, those treatments for advanced lung cancer, metastatic lung cancer, and over 50% of people get diagnosed with metastatic lung cancer, unfortunately, for the reasons that we talked about, for the work that my colleague, also Matthew Thompson, have been doing around lung cancer, for the reasons, I mean, there's that, they're not dying because of the work of Matthew Thompson, sorry, I phrased it wrong, because of the difficulty in recognizing cancer early. And I can invite Matthew actually to say a few words on this, if that's okay with the group. So the challenge is, again, with this, people present with symptoms. The symptoms are vague, they're non-specific, and people do not get diagnosed. But then let's say you got diagnosed, you had treatment, but even with your EGFR, ALK, or ROS, your treatment could fail and will fail eventually. My treatment's going to fail eventually. Then I'm going to have to scramble. I'm going to have to find the next line. If I don't have that oncologist or the doctor who is going to be on my side to say that, hey, we're going to try, we're going to push, and I know the cutting edge stuff, then I might also not be offered the same opportunity. So that is a problem. But again, the key thing is, especially nowadays with advanced lung cancer, where the opportunity is steering people toward getting those testing and receiving those treatments. And again, I would ask Matthew to comment about the challenge with diagnosing lung cancer early and the work that can be done in this area.
Good. Thanks, Mohav. Yes, I think, as we all know, the challenge with lung cancer is if only we could pick it up early, we could send our patients to doctors like Fahud. He could do surgery and remove it, just like early breast cancer or many early cancers. But sad truth is we don't pick it up early, and most patients present late when there's exactly the treatments that may or may not be available, like Fahud's mentioning. But the challenge is, and I think we're seeing fairly strong evidence that people with lung cancer seem to start noticing something maybe 9 or 12 months before they're diagnosed, which is intriguing. It's scary. It's kind of blows your mind to think that is the cancer really developing and brewing that slowly. And
what kind of things are they saying they notice?
Well, it's often very subtle things, and not the kind of things that even people might go to the doctor for, or maybe their spouse notices. Often very subtle things like feeling a bit more tired or doing a little bit less than they used to, which is hard to pick up. And many people, as we know, with lung cancer have other illnesses like COPD or other things. Which is it? The COPD? Is it lung cancer brewing? So it is phenomenally difficult, and there's been a shocking lack of research into this early stage. I would say shocking, because I can't think of any other disease where we've kind of ignored, apart from screening, this early phase of the disease. We recently, with Fahud and Moharov, we looked at all the patients at UW Medicine who've been diagnosed with lung cancer in the last 8 years. Only 1 in 20 were diagnosed by screening. So we could do more screening, which would be great, but it's never going to be enough. It's not enough for colon cancer. So screening is an answer, but it's not the answer. So how do we work with people who've had lung cancer, their caregivers, to try and say, these are the red flags you should look for in your spouse, your father-in-law, your mother-in-law, but we don't even quite know those yet. So that's the work we need to do, like right now. That's my passion.
Your passion is finding out what are those things that are indicators that we're seeing are indicators as time passes, elapses, right? And it's hard to do that in the moment because they seem to be so subtle. And there are, what I'm hearing you say is, there also are these indicators that we don't know are indicators until after the fact, until X amount of people have also stated they felt A, B, C.
That's a far more eloquent summary than I made. That's excellent. I wish I could have recorded that, because that's exactly you've summed it up in a nutshell, exactly there. And I think doctors, we get very used to seeing people as kind of snapshots. We're seeing you today for 20 minutes. Yep. We're seeing you again. But whereas life, of course, is more of a video. People are changing.
Right.
And I'd say doctors, particularly even in primary care, I think we tend to see people in these little snapshots. And it's hard to think, well, you're just seeing someone for 15 minutes every couple of months or once a year. Actually, that person's life is waxing and waning. Things are happening. Yeah. We just don't have a good way of seeing that evolving illness, or slowly changing, not walking up the stairs quite as fast, or weight just beginning to get losing a little bit of weight. So it's these subtle things that we need to work on. And
I hear you say screening, if I might just ask this question. Yeah. And this is probably going to be very obtuse, but what is that screening? Like, what is this screening that we're saying? What does screening for, as far as our knowledge has arrived at this point, what is proper screening for lung cancer?
Well, the screening, the correct medical use of screening is what Fahud was explaining. These kind of recommendations for CAT scans in certain age, certain
50
smokers,
to 80. We see that the benefit outweighs the
word screening is often used in a more general term for like what symptoms should you screen for, or what things should you look for? And I prefer the word, what should you look for? What should you be on the, what should you be suspicious about or search for? Certainly chest symptoms, coughing, short of breath, chest pain, but even subtle things like feeling pain, bone pain, chest pain, feeling more tired, losing weight, or all of these, I'd say some, and then occasionally people start coughing up blood, which doesn't happen very often, but it's those kind of things that doctors have been told to look for. But by the time you're coughing up blood, it's not very often, and it's kind of towards the end. So if we wait for the blood to be coughing up, when you don't have to be a rocket scientist to figure out something's going wrong, it's too late. So we need to educate patients, the communities, as well as doctors. But it can't just be doctors, because we'll miss it. I think we'll miss it. Yeah.
I had a quick question, add to a comment quickly for Dr. Thompson, in terms of when people ask me, they said, well, Maisha, what were some things you probably noticed? And I think I shared previously, and you're like, okay, if I go back, my husband had back pain, but we went to the chiropractor. He had 2 herniated discs. So we thought it was, hey, and then when that didn't work out, it's like, hey, you probably need to operate on your herniated disc, right? And then he went to the hospital for his shoulder gave out. And then, and it progressed. I'm thinking, what's going on? But then I thought, well, wow, while I'm working in a medical institution and trying to understand curriculum that doctors, for medical school students need to understand, is that something that could be possibly integrated into the, medical schools and the curriculum? I know when you go into your specialty, later on in your residencies, it may be a bit different, but is this something maybe we could start for educating clinicians and then also the community? Because I think, just in tandem, it's not just siloed education, but it's all around.
Absolutely. And, think how well we've done with empowering women to examine their breasts.
Yes, exactly.
Find something's wrong and go to the doctor. That evidence has showed it's far more successful having women examine their own breast regularly than it is for a doctor to do that once a year or once every couple of years. It's not that it's bad having the doctor doing it. It's just much better if you feel empowered to examine yourself, notice something and like, something here, I need this checked out. It's not quite as easy for the lung, of course. You can't feel your lungs. But finding ways to educate that are a little bit more sophisticated than coughing up blood or just having a cough, but how can we make something a bit better, a bit more sophisticated? Then eventually there are people working on blood tests that at some point in the future will pick up early lung cancer and early other kind of hidden cancers. But we'll need to know who to use them in. Can't use them in everybody. If you're a 22-year-old, you probably don't do it. But if you're a 40-year-old who've got this, that, and the other, the back pain you mentioned, maybe those are the patients who we should say, your risk looks like a little bit higher. You need something more. Could be a CAT scan, could be one of these new blood tests that are coming out. But we'll need people educated rather than just a free-for-all. It won't work if it's a free-for-all. And because the people who can afford it will get it and overuse it, and the people who can't afford it and probably need it won't be able to afford it and won't get it. That's the way that health technology tends to go, doesn't it? Yeah.
Dr. Thompson, I really appreciate that. I know that Dr. Moorhoff has a question. I'd love for you to ask it, Dr. Moorhoff.
Yeah, I think that actually a good segue, and Opal is taking us there to the conversation about surveillance and survivorship. This is where those same questions actually continue to be on the mind of someone with cancer. In a sense, how do I watch for my cancer to come back? Is this shortness of breath that I'm getting, is it my cancer again? There's the cancer is traumatizing experience, and then you'll be watching.
Or is it just you're out of shape? Yeah, you know what I mean?
Exactly. So that, I think that is a very good question. And as Matthew's saying, there are those surveillance, of course, that you come to the doctor on 3 months, 6 months, or a year to see, and that varies depending on where, were you treated surgically, or are you still ongoing with your treatment? Or is there other things that you can pick on along the way, so you can have conversations with your oncologist, with your treatment team, so you can jump on treatment next and quickly and effectively before things get out of control. And I'll leave it to Upal to move that conversation. I think Farhood can comment as well.
I was actually going to ask Dr. Farooq to kind of comment on this concept of survivorship, and what's your advice to patients, Dr. Farooq, when after your patients have had surgery? For most patients, it's a one and done, right? That I'm cured in my head, but what advice do you give them about survivorship? And I want to ask the same question to Morhaf as a survivor of advanced stage lung cancer. So Morhaf, keep that in mind. But I'm going to start with Dr. Farhood about how you define survivorship and what's the advice you give to your patients.
Thanks for the question. So a very narrow but important view of survivorship is surveillance. So when we say surveillance, what we're looking for are two things. We're looking for cancer coming back, meaning recurrent lung cancer, or a brand new lung cancer. Now, when I mention this to people, they've never even thought about that. But it turns out as long as you have lungs, you can get lung cancer, even if you've previously had lung cancer. So the way we tackle that is surveillance. And the way we do that is CAT scans. And we also have office visits. During those office visits, when I have those visits with my patients, it oftentimes feels like it's a lot of chit chat rather than me grilling them on, you have a cough, you're coughing up blood, things like that. But the chit chat is actually really important because that's when you pick up on those things that are small changes in their life, like their energy levels being low, or a new cough that they're blowing off to allergies, but maybe the new cough is a sign of trouble. So the office visit's really important, and the CAT scans are important too. But survivorship goes beyond that. It goes towards living a healthy lifestyle. It involves dealing with the consequences of treatment. Cancer treatments are tough, whether it's surgery, radiation, chemotherapy. Surgery leaves obvious scars, but the other treatments also leave their own scars, whether they're physical or mental, and having to reconcile those things are an important part of survivorship. And it's also screening for other cancers. It's once you have one cancer, you can be susceptible for others. So survivorship goes beyond surveillance, but surveillance is an aspect of survivorship. And I think, others on this call, Morhaf, and especially can talk about this notion of survivorship and how, lung cancer, if it's in its early stage, is episodic. It's like having a cold. Except in this case, you cut it out and hopefully it's gone. But in terms of later stage lung cancer, if we can't cure it, then one of our goals is going to be to prolong life. And in that way, lung cancer almost becomes a chronic condition, like diabetes or hypertension. And so those are aspects of survivorship that I don't see as a surgeon, but I think, Morhaf, you're probably well suited to answer that question with both the perspectives that you offer.
Yeah, so thank you, Farhood. I get CAT scans every 6 months. I get those images of my chest to see if my cancer has come back. And I have asked my oncologist more than a couple times to start those early on, whether that's because my anxiety was creeping up or whether I'm feeling some symptoms that are concerning, and they were kind and responsive to my concerns. So that is particularly important. I've interviewed 40 cancer survivors with advanced lung cancer who are taking targeted therapy, and as Farhood said, for many of them started to live like chronic disease. They are living their life. They're going back to working, some of them full time. They're going back to doing the activities that they like to do. And again, we're speaking here about people with privileges of receiving molecular testing and starting on the right treatment. For many of those people are continuing to do the things that they like to do. And this is a very important message of today's conversation, that lung cancer is not a death sentence. You can get lung cancer and you can survive for 5 years, and you can become an advocate for people with lung cancer. You can do that, and many people are doing way more, whether that's to be around their kids, being around their family, doing their hobbies that they've always enjoyed to do, and restoring, and even doing more, because once you start to feel like, man, life is short. So you need to do what you can to enjoy it and to live it to the fullest. So there are a lot of positive things about the experience of people who live with lung cancer. Of course, I always say, you know, for anybody who don't be envious of me. If you want my cancer, please take it, and I would give it for anyone. But not I would not give it. I would not wish it on my enemy, actually. And I would not give it to anyone. But if some people feel, you know, I've really, you know, shined up, brightened after I developed cancer, which is actually really the case. I found authentic voice, and I learned about love, and I found love, and I was heartbroken, and all those stuff, and I've lived a full life in the past just 5 years. So that's always that is a possibility. That does not undermine the needs for people. And as Nikki, I would like to invite her to share some about those needs for people, need for understanding, support, mental health as well. And I would leave that to Nikki.
Well, and thank you so much. What I have seen is that there's not enough support group. There's not, you would think by, 2021 that we would have kind of evolved more in the cancer space, and that, there I am, sorry. And that there would be more support groups. I get so many people asking me about support groups for their particular cancer. I know that art and medicine is huge. Just the art piece in for mental health for those that are going through a medical crisis. Very supportive of the arts, but like just like this, like I don't think there's, of course, breast cancer, you know, is almost like it's the only cancer that there is because they're so well funded. You know, you've got the NFL, you know, supporting breast cancer, which is like, I guess, supposed to be sexy. And I mean, there's everyone that's pouring into breast cancer, and breast cancer is very serious. But there are, like, you know, like we're talking now, lung cancer is the #1 cancer killer among all cancers, and colorectal, you know, ranks high. But, you know, where are the support groups, you know, at our institutions? I think we can really grow that, because, you know, you were sharing about, okay, yeah, if you've got lung cancer, you know, it can come back. So for a cancer patient, I'm sure those that are on this call that are survivors can, you know, I'm sure it's like always, it's like the monkey on your shoulder. And, you know, and I've heard, is it today? You know, is it going to come back today? And I mean, that's a lot of weight to carry. And you can't carry that yourself. You know, we have to have these conversations and develop programs for the patient and for the caregiver. There's not enough programs for caregivers. Thank you.
Thank you, Nikki. I know we are about to close. I just would like to ask the panel, what is an action item? What is the one action item you would like for us to take away from this discourse? Because I know I want to apply it to my life.
I can start. The first said, I got something to say, and everyone got something to say. Even if you have cancer, you got a lot to say. As a matter of fact, if you have cancer, the urgency becomes louder for you to say it, and to say it loud and clear. We need to change the narrative around illness. We need to invite people who develop those illnesses to stay in the center. We let a lot of people down, and we leave them on the margins. Unfortunately, especially in our Black communities and our people of color communities, immigrant communities, refugees, people, the poor, people who do not have access or privilege. And this needs to change. We need to change the narrative so people can stay and participate. And we need to have that equitably available to every person.
Thank you, Dr. Morhoff. Thank you, Dr. Farhood. Thank you, Nikki. Thank you, Dr. Thompson. Thank you guys all. Upal, do you have anything you want to add or
I just want to echo your gratitude, Shay. Thank you so much for joining us and for sharing your experiences. It's been such a great discussion.
Thank you.
Thank you.
Have a good night.
Take care, everyone.
right, take care, everyone.
Bye-bye.
Thank you, Maisha. Okay.